I'd like to thank Dr. Chapman and Dr. Askuyan for inviting me today. And following such a terrific round of talks is a little overwhelming. So hopefully everyone will bear with some simple anatomy of the craniocervical junction. So obviously to this crowd, this is an area that's interesting, and the applied anatomy here is substantial. This little area at the base of the skull and top of the spine is packed with very formidable anatomy, and having a good working knowledge of the morphology here is not only useful, but something that's a must for operations. Obviously, disruption in this area is often not compatible with life. And what I'd like to do is start by taking you from the ground up. Again, this is serve as a review for this crowd who knows this embryology and anatomy quite well. So third week of development, there's gastrulation, and we have a three-layered disc made up of endoderm, mesoderm, and ectoderm. Remember that a notochord, a derivative of mesoderm, forms down the middle and induces the overlying ectoderm into neuroectoderm. The mesoderm is going to essentially develop into periaxial mesoderm, lateral plate mesoderm, and intermediate mesoderm. It's the periaxial mesoderm that we're concerned with, because that periaxial mesoderm is going to give rise to somatomeres and then somites. And it's these somites that are the building blocks for what we're going to find in the craniocervical junction. You'll all remember that each somite will then diverge and become either dermatome, skin, sclerotome, bone, or myotome-associated muscle in the region. So a very nice schematic that shows you the formation from the sclerotome level. You can see in the middle here, sclerotome level, and how those sclerotomes form into our somites. You'll see the upper four somites in the occipital region don't go through the same differentiation that the lower sclerotomes do. And you'll see that the fourth occipital somite is a transitional somite, and this is called the proatlas in red. And that proatlas, you can see, gives rise to not only the occipital condyles and the articular facet of C1, but also the tip of the dens, a little of the posterior arch of C1, and then some of the Bayesian. You should also remember that running up through this region in the fetus is that centrally located notochord that runs up through the odontoid, then takes a left angle direction up through the clivus, and then pierces up through the dorsum sella. Bony development of C1, the upper portion of our craniocervical junction, begins by the ossification of three centers. We have two laterals and then an anterior arch region that's seen here for B. This gives us the development of our adult ring of C1, which is in essence a typical vertebra that's lost its body to the C2 below, which will be the dens. These slides are available online, so you can feel free to look through at all of the dimensions. Some of the more attentive type things to pay attention to. One would be that the sagittal distance and the coronal plane distance of C1's vertebral foramen is roughly equivalent to what you see at the foramen magnum, so about 35 in the sagittal region, and then coronally it's about 30. As you go down, we'll come to that, to C2 spinal foramen, you'll see that it's a little bit reversed, so that the AP distance is slightly longer than the vertical distance. Some variations of C1 that one sees: epitransverse processes, pericondylar processes, arcuate foramen, bifid posterior and anterior arches. Here's some examples of pericondylar manifestations. So these can either arise from the lateral portion of C1 and grow up towards the pericondylar process. There can be a false articulation / joint here. You can also have processes that come down from the pericondylar region and fuse to the C1 vertebra. An arcuate foramen, as you see there on the right, as the vertebral artery comes up through the transverse process of C1, it then wraps around in the vertebral groove. And in this individual, there's a bony bar that has formed a foramen there, and the vertebral artery is seen there. And one of our studies, we showed that in almost all of the specimens looked at that had an arcuate foramen, the vertebral artery was compressed from its pre- and post-foramen caliber. C2, remember, is simply a typical vertebra that has the body of C1 that's incorporated into it as the dens and allows for increased axial rotation. It develops from 6 different ossification centers. We see 2 in the midline of the odontoid, body, 2 lateral masses, and then the apex of the dens. Again, some basic measurements. The length of the dens is around 15 millimeters, depending on what ethnicity you come from. The foramen length at this location changes from above, from C1 that's 35 by 30 roughly millimeters to something that's 25 by 20, and 20 being in the sagittal viewpoint. The odontoid, if you look at its inclination, it has an average inclination in normal non-pathologic specimens of about 97 degrees. This amount of retroversion that you can see can increase when you have pathology such as Chiari malformation, so that there's increased anterior compression at the craniocervical junction. The second slide, you notice a measurement that we use fairly often in our clinics, and that's a PBC2 line. And that distance between the anterior dura and the posterior aspect of the odontoid should be less than 9 millimeters. Here we see the orientation between odontoid and anterior arch of C1. That pre-dental space, as we all know, should be 3 millimeters or less in adults. It can be up to 5 millimeters in children, and anything over 6 millimeters for that pre-dental space is indicative of transverse ligament avulsion. Some variations of the odontoid. We are all familiar with ossiculum terminale. You can also have hypogenesis, agenesis of the odontoid, os odontoideum, dens bicornuous, which is shown here in the upper right, where there's basically a bifid nature to the tip of the dens, and then a completely bifid dens, where the entire dens is split all the way down to the body. The occipital region with occipital condyle shown here, foramen magnum, which is about 35 by 30 in its measurements, length being greater than width. You notice the occipital condyles are on the anterior half of the equator of the foramen magnum. Foramen magnum comes in lots of different sizes and shapes. These are some of the more common. 2 semicircles is in this study found to be the most common, and the range is variable depending on ethnicity. One important relationship shown here, and especially for condylar screws, is the direction of the condyles to the foramen magnum from a posterior lateral to a posterior medial orientation. We looked at the different surface areas of the foramen magnum, and these come in wide varieties. The type 3 is greater than 600 millimeters squared. Most of ours were in that type 2 region. Some variations of the foramen magnum, obviously condylar hypoplasia, atlanto-occipital assimilation, occipital vertebrae, which are thought to be derived from pro-atlantal derivatives, third occipital condyles, which are in that same category and are found near the basion. You can have bilobed occipital condyles, stenosis of the foramen magnum seen with achondroplasia, enlargement of the foramen magnum seen with Chiari 2 malformation or children with myelomeningocele, and Kirkring's ossicles from this slide that you may occasionally see as small secondary ossification centers on the posterior aspect of the foramen magnum. Ligaments at the craniocervical junction. We also know the anterior longitudinal ligament that's seen here on the left, ascending up on the anterior vertebral bodies, and as that runs between C1 and the base of the occiput, it changes its name to the anterior atlanto-occipital membrane. A stronger membrane compared to the slide on the right, which shows the posterior atlanto-occipital membrane running from C1 up to the base of the skull. It's this posterior atlanto-occipital membrane that the vertebral artery first pierces prior to going through the dura and becoming the V4 segment of the vertebral artery. An anterior ligament that's seen best posteriorly, and this slide on the left, obviously not compatible with life, but shows you very nicely the tectorial membrane, which is an extension of your posterior longitudinal ligament. and this tectorial membrane extending up onto the clivus around the jugular tubercle. If that's reflected inferiorly, you get the slide that's shown there to the right, showing the cruciate ligaments, alar ligaments, and the accessory atlantoaxial ligaments. Tectorial membrane, we've looked at this in some detail in cadavers, and it has a much higher, superior attachment. It has more elastic fibers than does its derived structure, the posterior longitudinal ligament, and it becomes taut in flexion at about 15 degrees and taut in extension at about 20 degrees. Transverse ligament, thought to be basically a modified intervertebral disc. It's a proatlantal derivative, as is the alar ligaments. It's about 22 millimeters long and has, as we'll see a little bit later, a fairly high avulsion force necessary to avulse this ligament. Alar ligament we see as running at about 70 degrees in the coronal plane off of the sagittal plane. It's again a proatlantal derivative, about 10 millimeters long. This is a nice depiction that shows on the left lateral flexion to the right, and you see that the right alar ligaments become tense with extreme lateral rotation, lateral flexion, and then on the right with rotation contralaterally, you see that the contralateral alar ligament becomes extremely tensed in that direction. Accessory atlantoaxial ligament, this is and historically thought to be a deeper part of the tectorial membrane. In the study that we performed, it was always a very separate structure. It's about 30 by 5 millimeters. It's lax in extension and becomes maximally taut in 10 degrees flexion. The apical ligament that you see extending from the tip of the odontoid up to the basion, once thought to contribute to craniocervical stability. In our study from 2000, we found that it contributed almost zero to craniocervical stability. It was absent in up to 20% of the specimens, and histologically is just essentially a derivative of the notochord. Lateral atlanto-occipital ligament that we see here, running from the jugular process of the occipital bone out to the transverse process of C1, is a good landmark for the jugular foramen for anterior approaches. And a study performed by our group showed that the relationship between it and the vertebral artery is intimate and puts the vertebral artery in danger if you're in this region. It has about a mean angle of 26 degrees off of the midline, and it's lax with flexion. Nuchal ligament is an interesting ligament in that it runs from the skin to the posterior surface of the spinous processes of the upper 7 cervical vertebrae, and in quadrupeds contributes significantly to helping hold the mass of their head off of the ground. In humans, where holding the head off the ground is not a big deal anymore, this ligament has become more of a septation type structure, and in humans has lots of proprioceptive fibers, so it contributes more as telling the brain where the head and neck are in space compared to helping hold the head up. A little ligament that most people aren't familiar with, the transverse occipital ligament that you see there is the third listed structure on the right. This is found in the majority of cadaveric specimens. We did a study, and it's there. It prohibits some minor rotation of the craniocervical junction. This is a nice outline that shows you some of the major players as far as ligaments of this region. Transverse ligament by far is the strongest and is the one that you want to maintain integrity for. However, capsular ligaments of both the occiput and C1 and C1, C2, most people don't consider those as strong inhibitors of rotation, and they're strong at 300 newtons before they avulse. Alar ligaments, tectorial membrane, and then far at the bottom of the list would be the lateral atlanto-occipital membrane. Some muscles in this region with dissection and removal of the trapezius. One first comes up on the splenius capitis, shown here. If you reflect the splenius capitis, we see the semispinalis capitis and the emergence above of the greater occipital nerve. There below that, we see the C3 or the third occipital nerve. And then very nicely shown on this picture, you see in the midline, there's the nuchal ligament that's basically serving as an attachment site for these paraspinal muscles. Deep to the semispinalis capitis, we see the suboccipital triangle, and then here, as C2 spinous process is in the middle of the screen, you see the semispinalis capitis attaching there. Within that suboccipital triangle, we remember that there's some important structures: vertebral artery, suboccipital nerve, vertebral venous plexus, posterior arch of C1. Some of the morphometrics of the suboccipital triangle you can see in this image, and we see the three muscles that contribute to this triangle: the obliquus capitis superior from C1 to occiput, the obliquus capitis inferior from C2 to C1, and then traveling between, shown in this picture, C1 and occiput is the rectus capitis posterior minor. Not to forget some of the anterior muscles of this region. Here at C1 connecting to the occiput, we see laterally the rectus lateralis, and then more medially deep to the longus capitis, we see the anterior rectus muscle. Veins in this region, the craniocervical junction, primarily are Batson's plexus in the paraspinal region, both in and outside the dura, and then these primarily communicate with the marginal sinus around the foramen magnum, which has strong contributions from the basilar venous plexus and from the veins of the hypoglossal canal. Marginal sinus we've looked at in the past in a study, and many of these are pierced by the vertebral artery, pierced by the rootlets of the hypoglossal nerve, and have strong communications between sigmoid sinus and occipital venous plexus. This is a nice suboccipital venous plexus shown on the left, and these are contributed to by the deep cervical vein, the occipital veins, and the perivertebral artery venous plexus. Main player as far as arteries in the craniocervical region, the vertebral artery is number one. If you remember from your embryology of this region, this begins as a branch of the dorsal aorta or aorta. There are segmental branches that come off and run in the horizontal plane, and then with regression, small linking vessels between the vertebral and the segmental branches form what we call the adult vertebral artery. You can have some of those linkages that maintain themselves into the adult. For example, here we see all of the intracranial and craniocervical persistent fetal vertebral basilar connections. So trigeminal artery, otic artery, fairly common, a proatlantal artery that's seen here connecting the vertebral artery to the internal carotid artery if it's a type 1. And most embryologists these days believe that this proatlantal vessel is in essence, in the adult human, the V3 segment of the vertebral artery. So as one approaches the V3 segment of vertebral artery is seen here after it's come up through the transverse foramen of C1 and runs on the back border of the posterior arch. We see this type of phenomena so that the artery has a medial to lateral course from C2 up through C1 transverse process, and then swings back medially in a horizontal plane. Remember, that's derived from the proatlantal artery, then enters the posterior atlantal occipital membrane, pierces the dura, and then becomes the V4 segment of this vessel. You'll notice also from this slide, especially on the right, that some of the intimate anatomy here is that the vertebral artery is anterior to the highest dentate ligament at the foramen magnum, and is also the spinal accessory nerve drapes over a vertebral artery at this location. Vertebral artery is usually greater in size, diameter on the left side. It's about a 5 millimeter diameter vessel in general. It can be compressed with extension of the AA joint, atlantoaxial joint. And about 30 degrees of rotation, you're going to kink the contralateral vertebral artery, whereas 45 degrees, you're going to kink the ipsilateral vertebral artery. The vertebral artery can be smaller in size if you do have a known proatlantal vessel. An interesting measurement as far as from the midline to when you're going to come upon the vertebral artery laterally, that's about 20 millimeters. It's variable and also based on size, but that's a good number to carry around in your pocket. Branches of vertebral artery, we see various things. Most of these are heading to the spinal cord. For example, these radicular branches, radicular muscular branches. We have lots of anastomoses in this area between the, for example, ascending pharyngeal artery, The posterior meningeal comes off in this region, and one important variant is that your posterior inferior cerebellar artery can arise from the extradural component of the vertebral artery, that's V3, and has to be considered when you're doing coagulation in this area. A study we performed showed the greatest concentration of branches of the V2 segment in this region go out to your C2 and C3 parts of the spinal cord. Largest branches of the vertebral artery occur from this segment in general. For the bone, remember that this vertebral artery venous plexus coupled with these ascending pharyngeal branches supply a nice odontoid arcade that surrounds and bathes the bone of the craniocervical junction. Lymphatic drainage, not a lot is known about it from the craniocervical junction. We do know that lymph from this area drains to the retropharyngeal lymph nodes and then into your deep cervical chain, and that this is the most likely pathway for a Grissel syndrome with a peripharyngeal inflammation. Innervation of this region, there are multiple nerves. Some are muscular, some are cutaneous, some are both. From this, we see if we go from left to midline, we see the great auricular nerve, which is usually outside of the field of most craniocervical approaches. The lesser occipital, more apropos to the craniocervical junction. In the midline, we see C2, and that's the greater occipital nerve. And then the closest to the midline is the third occipital nerve, derived from C3. You can see on the right where the trapezius and overlying superficial muscles are removed, that the greater occipital nerve emerges just below the inferior oblique muscle and then courses up through the muscles, pierces semispinalis capitis and trapezius before it comes out onto the back of the skull about 3 centimeters lateral to the inion. The suboccipital nerve that you can see inside the suboccipital triangle here innervates those suboccipital triangle muscles, and clinically I think is probably somewhat inconsequential. This is a deeper dissection that shows you the greater occipital nerve coursing up through semispinalis capitis. We see the third occipital nerve closer to the midline, and then the smaller suboccipital nerve in the triangle. Occasionally someone will find branches of that suboccipital nerve that go out to the skin of the occiput and basically bring C1 into the dermatome pattern. Deeper nerves in this area, you can see after you remove posterior arch of C1, we see the dorsal rootlets of C1, which are present in about half of the specimens. And then the larger here is C2 going out to the DRG of the second vertebral level. This is a good view of spinal accessory nerve and its spinal component, which runs through the upper five spinal cord segments. We looked at the C1 dorsal root ganglia in their dorsal rootlets, and in essence, you see it in about half the specimens. In this half, about 1/4% of those have an associated dorsal root ganglion. And then if you see spinal accessory nerve, it often will join with the dorsal rootlets of C1, and in those cases you don't see dorsal root ganglion associated. And the thought is that the neuronal cell bodies of those fibers are traveling within the spinal accessory nerve. Last couple of slides, just to get through this so we can get to the lab and see some of this anatomy. These are movements that you can carry around in your pocket as far as the essence of mobility of craniocervical junction. The last two dots there are good take-home messages. About 75% of axial rotation occurs at C1, C2. That's intuitive. Maybe not so intuitive is that 4% of axial rotation occurs at occiput C1. You'll see, starting at the top, that occipital joint flexion is about 10 degrees, extension is about 20 degrees. Lateral bending of the AO joint is anywhere from 6 to 12 degrees. Rotation of the AO joint is 0 to 5 degrees, depending on how you measure that. Rotation of the atlantoaxial joint is about around 45 degrees as a mean. And atlantoaxial flexion and extension are about 10 to 12 degrees. Some lines that help us clinically, and everyone knows these in the crowd, I hope, and have varying degrees of application. One of these, Wackenheim's Clival line, is useful for making sure there's not any basilar invagination. McGregor's and Chamberlain's lines are both, in essence, from the hard palate to the Opisthion. People have made lots of different little measurements that are very subtle between the tip of the odontoid and the basion, or between the posterior arch of C1 and the opistheon. Those are difficult sometimes to digest in the clinical scenario. So a better way of looking at this is probably the ratio that Powers developed, where one takes the basion to the posterior arch of C1 and divides that by opistheon to the anterior arch of C1 and gets a ratio. So that ratios greater than 1 indicate that there may be some anterior subluxation of the craniocervical junction. So that's a very quick review of some anatomy that we find at the base of the skull and top of the spine, and hopefully that will be useful to you when we're across the hall and looking at some of that specific anatomy. Thank you for your attention.
Hey, thanks for visiting the Seattle Science Foundation YouTube channel. To find videos just like this one, click here. To subscribe to our channel, click right here. Or check out our website here, or see what we do by clicking right here. Thanks again for watching.